Good afternoon. Today is March 18, 2025, and we are going to start our SSAT webinar series today with a very interesting topic that is about esophago-gastro-intestinal anastomosis, magnetic anastomosis. So we have a very selected group of people that is going to talk on this interesting webinar, and I will be with my two co-moderators, Dr. Anne Lidor, Chair of Minimal Invasive Surgery at University of Wisconsin at Madison, and Karen Gibbs, Chair of the Department of Surgery at Yale University in Bridgeport Hospital. So we welcome all of you. I hope you enjoyed the presentation. This is very interesting. Now it's a hot topic in every conference we go. So I hope you get to learn something, and perhaps you can look for opportunities to expand your practice. So let's start with the first presentation, and it's going to be done by Dr. Anatol Korlovsky. He is a graduate from the Russian Medical University, practicing at Royal Brisbane and Women's Health Hospital. He is going to present us compression anastomosis, history and clinical considerations. So welcome, Anatol. The podium is yours.
Thank you. Oops. Good afternoon, and thank you for this privilege. As a pediatric surgeon of Russian background, as a young trainee, I proudly participated in a pilot MCA project conducted at my alma mater in Moscow during the 80s. Our publications were limited and in Russian only. My current review included 175 more recent publications on MCA in gastrointestinal applications of a broader spectrum, featuring novel magnetic devices, specifically focused on Mees and Nodes approaches in both adults and pediatric patients. However, MCA is still not standardized to replace hands-on and stapled anastomosis. Although the largest clinical series by Professor Umanuchi comprised 422 patients, the recent publications are still largely of small patient series and case presentations. Today, I will outline biomechanical fundamentals and clinical limitations of MCAS from our Moscow experience, which I believe are now pertinent to clinical considerations of its future standardization and advancement. Historically, MCA is actually a derivation of sutureless mechanical compression anastomosis from 2 centuries ago. In 1827, a pioneering French surgeon, Félix Nicolas Denon, presented the first intestinal anastomosis device by means of co-opting rings, which he experimented with in animal models. In 1892, the legendary American surgeon John Murphy thoroughly tested in animal experiments and widely used in clinical practice. In the 20th century, mechanical compression anastomosis was technically advanced with sophisticated novel devices. Among those innovators was...
Excuse me, Anatol, your slides aren't moving forward.
Yeah, not moving, sorry.
Sorry?
They are not progressing the presentation with the slides.
Can you go with the presentation mode?
Oh, you can't see my screen.
I can see your screen, but it's not moving.
Not moving. It's moving on my screen.
No.
Can you see what picture, what slide you can?
Just that we just have seen the title slide.
the title slide. Oh my God. Just a sec. Oh. It's moving on my screen. It's now back to title. And can you see it now?
I would suggest unsharing and then share it again.
And limitations of MCA as from our Moscow experience, which I believe are now pertinent to clinical considerations of its future standardization and advancement. Historically, MCA is actually a derivation of sutureless mechanical compression anastomosis from 2 centuries ago. The first was a pioneering French surgeon, Felix Nicolas Denon, who reported on first anastomosing device, which he experimented with on an animal model. In 1892, the legendary American surgeon John Murphy published the original manuscript on his famous anastomosing buttons, which he thoroughly tested in animal experiments and widely used in his clinical practice. In the 20th century, mechanical compression anastomosis was technically advanced with sophisticated novel devices. Among those innovators was Nikolai Kanshin of Moscow, who in the parallel development first reported on experimental MCA in 1978. In 1980, Janssen from the Netherlands reported on the first clinical experience with MCA in colorectal resection in adult patients. Our subsequent Moscow experience was then the first exploring MCA in aspects of biomechanical evaluations, technical rationalization, and clinical appraisals of its effectiveness in the specific applications for pediatric surgical conditions. The results of our experimental evaluations on 250 animal models confirm the rationale for MCA as an alternative to hands-on anastomosis. Technical experiments demonstrated MCA feasibility and simplicity, particularly in transluminal mode. Biomechanical and morphological studies showed magnets' capability to form a secure MCA of superior quality with high mechanical strength, healing by primary intention and without resultant scarring. Specifically, MCA bursting pressures at early post-op intervals were twofold greater than in sutured controls. Morphologically, as an example, MCA between the ureter and urinary bladder at 2 post-op weeks resembled the natural ureteric orifice. In contrast, the sutured control showed ongoing inflammation. Histologically, epithelialization at the compression line was fully completed, whereas in the control sutured anastomosis, there were foci of separation around suture material. Considering MCA optimal formation, the healing process appropriately developed under optimal compression in a balance between the radius of the pressing magnet surfaces, which shape the remodeling zone. In the central zone, the maximum compression was required to ensure magnet's reliable cooptation and instigation of desiccation of the subjected tissue. At the demarcation line, epithelialization then progressively proliferated and displaced the thin rim of desiccated tissue together with magnets within 7 to 10 days, thus completing primary healing. The adverse events, however, inevitably encountered when simulating compression imbalance is all. force was inadequate to attain reliable magnet cooptation, the higher resulted in an impeding perforation. Our clinical outcomes with MCA in gastrointestinal applications involving the original techniques of esophageal recanalization, Svensson pull-through, and ileostomy reversal record success in restoring intraluminal patency at rates 60 to 95%. The adverse events, however, included 1 esophageal perforation and 7 stenosis, 5 after esophageal recanalization and 2 after pull-through. These adverse events were obviously associated with suboptimal compression, firstly, when sizable tissue was interposed between the magnets and especially when combined with anastomotic tension. The pathomechanism of MCA stenosis was then seen to be related to insufficient compression at excessive distance between magnets. Compression on the stricture scar tissue when healthy tissue was not included in the compression gradient or remodeling zone. These complications were actually correlated with the experimental findings when simulating compression imbalance. Contemporary evidence on MCA advantages and challenges now appears to resonate with the outcomes of our past experience. MCA feasibility, safety, and effectiveness with initial success up to 100% are generally confirmed in all recent publications. However, the subsequent MCA stenosis remains the issue, in particular in the largest clinical series and the most common after esophageal artery repair up to 100%. Regarding magnets characteristics in these reports, the available data on magnets flux density and magnets grades only indirectly imply magnet strength, but do not indicate actual compression force. The parameters of magnet compression, which from our past experience are fundamental for appropriate MCA formation, are specified in only one clinical publication. Further, there is only a handful of experimental studies that consider the optimal MCA compression, and the reported optimal parameters are inconsistent. In particular, in 3 studies from China, the data is up to 10-fold greater than that from the United States and also in our past experience. So, what are the optimal compression parameters? That is a question. In my view, the parameters of the optimal compression force and compression gradient are yet to be systematically established in order to standardize safe and efficient MCA in each specific application, minimizing the risk of recognized adverse effects. Specific example tool as universal driving device functioning to detect in real time possible biomechanical hazards should be engineered and commercialized. In closing, I'd like to direct you to this quotation of Michel Garnier. To make this dream come true, I trust that prospective technological standardization of MCA will be undertaken in a collaborative effort in the trajectory towards its universal and efficient use. Thank you very much.
Thank you so much, Anatol, for your presentation. This is going to give us some kind of base on what we are going to develop the rest of the webinar. So it's a little bit of story of history, and now we are going to talk a little bit more practical things. And I will ask Karen to present our second presenter, our second speaker.
Great, thank you. That was an excellent presentation. And now we're going to hear from Dr. Bethany Slater, who is an associate professor of surgery at the University of Chicago. As you can see from the previous conversation, the pediatric realm was very important as in the development of this technology. So Dr. Slater is going to talk to us about esophageal magnetic anastomosis in the pediatric population. Thank you.
Great. Thank you so much for having me and allowing me to participate on this panel. I will be focusing my talk about esophageal atresia and placement of magnets for those patients. And for those not as familiar with the pediatric population, esophageal atresia is a congenital anomaly in which the esophagus is not in continuity. Just in regards to disclosures, I am a consultant for Hologic, which is not relevant. I have been a consultant for Cook and the PI for the Flourish study, which I will be discussing in this presentation. So again, for esophageal atresia, this describes the anatomic classification. And for the purposes of this talk, we'll really just be discussing the pure esophageal atresia, in which there is no fistula and occurs in about 8% of the population of patients with esophageal atresia, and the type C, which is the most common type of esophageal atresia, in which there is a proximal esophageal pouch and a distal fistula. So for most patients with a classic type C esophageal atresia, they will typically undergo a surgical operation in the first couple of days of life, either open or thoracoscopic, as you can see on the right-hand side. However, there is a fairly high rate of complications after surgery for this type of anomaly, such as anastomotic leak, which we see in about 10 to 16% of patients. Strictures, depending on how you define it, is seen in about 80% of patients, and a recurrent fistula, which is a less common complication after the operation. As seen in this review article as well, rates of complications have been reported at about 60 or 65% and has been fairly unchanged for the last 30 years. Specifically looking at long gap esophageal atresia, in which it is difficult to bring the two ends of the esophagus together, is a very technically challenging group of patients. There are a number of factors that can limit esophageal continuity, of which I won't go into detail. Sometimes it's just that there's a long gap between the ends. Some are operative complications, or some have to do with patient characteristics such as prematurity or congenital anomalies. And there are many different techniques used in these patients, of which I've listed a variety here. Whenever there are a lot of different techniques for something, that means that there is not an optimal one. So suffice it to say that in typically long gap operative management undergoes multiple operations. Oftentimes they're repeated anesthetics with prolonged operative time and significant physiologic stress. So the question is there a different option for treatment for esophageal treatment? And that's where magnets come into play to be a non-surgical alternative for esophageal anastomosis. So the first device that I'd like to mention for esophageal atresia is the Flourish device. So this was an FDA-approved humanitarian device exemption device created by Cook, in which there's an esophageal and a gastric catheter with an inner magnet. It does taper to a 10 French coupling surface to allow for gradient compression. And it has a proximal portion that has a suction port to decompress saliva. And on the gastric portion, there is a channel for feeds, so these patients can still undergo feeds during the magnetic compression. And this figure on the bottom right demonstrates how it works. So the device is placed under fluoroscopic guidance, and the magnets are placed within the two pouches. They sense one another and allow for lengthening of the proximal and distal esophageal pouch. Next, once they're coupled, the magnetic compression continues, as already heard in the last talk, when the tissue between the two magnets becomes ischemic, leaving the outer rim and causing the anastomosis. And then the next one shows the completed anastomosis. So we did conduct a prospective single-arm observational study with the Flourish device to evaluate the safety and the benefits. It was a Cook-sponsored device. And this lists the eligibility for these patients. So patients with esophageal atresia and a gap less than 4 centimeters. That's very important for this device because longer gaps don't allow the magnets to sense one another. There needs to be a repaired or an absent fistula and a gastrostomy tract, which can accommodate an 18 French catheter. This shows the results of that study. So 52% of patients had a successful anastomosis, 11 of 21 patients. All of the patients did have a stricture that required dilation. 2 of the patients did go on to require surgical anastomosis. 1 patient had a small leak that was treated non-operatively. There was 1 mortality unrelated to the procedure, no other morbidities related to the procedure. And really the main reason for an unsuccessful anastomosis was just that the magnets failed to advance. So keep in mind that placement of the magnets don't cause any issues with then doing a surgical operation. So there's really nothing that was lost in these patients aside from the placement of the magnets as a procedure, but they were subsequently removed and patients underwent operative repair. The next device that I wanted to mention is the Connect EA magnets that are created by Mica Labs. So this is a different system in which there are 8mm diameter compressive device components. They do have to be introduced via an endoscopic approach, both transorally and via the gastrostomy site using graspers. And it's designed to create an anastomosis over a period of about 6 to 12 days, of course, without conventional suturing using the mechanical magnetic compression anastomosis. Just of note, this is not designed for pouch lengthening or for any type of long gap esophageal atresia. So for these patients, there needs to be an approximation of the pouches, and then the device system creates the anastomotic repair. This is just a slide showing how that works. So for the patients that have a fistula that needs to be surgically ligated and the 2 ends of the pouches need to be closed, then the Connect EA device is positioned into the bottom and the top of the pouches. Then the anastomosis forms, and usually there's spontaneous passage of the magnets after the compression anastomosis has formed. This is a paper from some of my colleagues who reported their experience with about 10 patients. And one of their really main points of this is that after about 3 months post-repair, none of these patients required ongoing esophageal dilation and all created successful anastomoses. So in conclusion, esophageal atresia magnet placement is a helpful role in the repair. The main complication, however, is a stricture. And I would like to point out, though, after the operative approach, particularly for the complicated patients, there is also a very high stricture rate. And then it should be noted that with the Flourish device, the magnetic coupling surface does narrow down to a 10 French. So there is some expectation of some narrowing after that. And magnets can be particularly beneficial for patients that are high risk for surgery, such as those with congenital anomalies, have had previous operations. And it can be used as a hybrid procedure. So we found this to be very useful for patients who have postoperative strictures, non-amenable to dilation. It can also be used in a staged fashion with longer esophageal gaps. And to keep in mind, something that can also be used is a thoracoscopic mobilization of the 2 pouches, and then use a magnet for the anastomosis, given that the technical aspects of a suture anastomosis in these patients are fairly difficult. So this might help adopt the minimally invasive approaches for this operation. Unfortunately, the Flourish device is no longer on the market. This was taken off not because of any safety issues, but because of the regulatory demands with the FDA. So currently it is off the market. I'm hoping that we can revive it and create a Flourish 2.0. So thank you very much for your attention. And after the panel is completed, happy to answer any questions.
Sergio, are we just going to do questions at the very end for everybody? Okay.
Yeah, we have 20 minutes for discussion at the end.
Okay, got it. All right, well, then I'll be happy to introduce our next presenter, who is Dr. Michel Gagné. Dr. Gagné is a very well-known bariatric surgeon and has been involved in many innovative procedures in bariatric surgery. He is practicing currently in Quebec in Canada, and he's going to talk about safety indications and results of small bowel magnetic anastomoses.
Thank you very much. You can see my slide because
Yes.
we never know. Okay. These are my disclosures. And as I said before, we are in bariatric surgery in a clash of the titans between the magnetic monster and the Gila monster from New Mexico, which is magnets by compression versus GLP-1 agonist. I think in the next decade, we have to see which monster will win. The delayed anastomosis technology is slow progressive compression. If we don't open the intestine, there's theoretically no bleeding and no leaks. If the compression is slow and not fast, and there's central necrosis with peripheral wound healing. We started with a study done in 2008 on the duodenal ileostomy for weight loss and type 2 diabetes by creating a duodenal bipartition, and this was a connection between a loop of ileum to the duodenum, and compared to control, we could see that the duodenal ileostomy resulted in pigs in less than 6% of weight versus growing pigs had 33% after 6 weeks of weight. Macroscopically, it was a very good wound healing, and endoscopically also. And histologically, we had good alignment of all the different tissue. We obtained a patent at the time for complete endoscopy, proximal and distal, to perform with 2 linear magnets this compression. We repeated the experiments with new design of 3 centimeter, a neodymium magnet encased in titanium to decrease the toxicity or not have any toxicity of a temporary implant. And there's a groove allowing healing in the periphery. After this confirmation, we embarked on a multi-institutional study in 4 countries and performed this magnetic duodenal ileostomy side to side, or duodenal bipartition, which is different than a single anastomosis duodenal ileostomy, which is an end-to-side anastomosis. This is a laparoscopic assisted procedure with 4 trocars at the level of the umbilicus. And this is necessary because we need to measure the intestine and perform the anastomosis at a specific site on the ileum that is 250 centimeters from the ileocecal valve. And that is the measurement that is used for the SSAT procedure or the duodenal switch procedure. It's a linear magnet that is transported in front of the endoscope, and it's attached to a catheter introduced in the working channel. Initially, it was brought to ligaments of Treitz and then transported to the marking at the ileum. Then the second magnet was introduced by gastroscopy into the first duodenum, and then we docked the 2 magnets without enterotomies. After formation of the anastomosis, this would pass in the distal small bowel and perform a duodenal bipartition. This is the first cases done in Tbilisi, Georgia. The first 5 cases were the first in human study. And then we went to Brussels for 10 more cases, in Madrid with Professor Torres, and in Canada, where half of the cases were done. We published this in surgical endoscopy, and you can see here the patients and the study visits. We are now close to completion at 360 days from all the patients. But we had 100% alignment of the 2 magnets with our first question, and passage without reintervention, that was 100%, and creation of patent anastomosis in all the 49 patients. If the magnet anastomosis was combined with a sleeve gastrectomy, we obtained an 86% excess weight loss at 1 year. If they were performed after a sleeve gastrectomy, just as an adjunct for weight regain, we obtained an extra 27% excess weight loss at 1 year. This was a 3-centimeter magnet. We also saw a metabolic effect, a decrease in hemoglobin A1C over time. Then we saw also a decrease in glucose. We also had some adverse events, as you can see. We recorded everything, we had grade 1 and grade 2 Gladnick classification mostly, and a few grade 3, but none grade 4 and 5. The surgery is reversible. We can staple at the duodenal ileostomy. We can also ameliorate and staple just below the anastomosis on the duodenum and do what's not a side-to-side, now an end-to-side. We obtained, the company obtained, GT Metabolic obtained FDA approval in July 2024, and now it's being performed in the United States. We went to a second design. This is a swallowable design. Now it's much flatter. There's an absorbable material around that permits less tissue encompassing the healing area. And this is next to the swallowable balloon called the Allurium balloon. We wanted to do this experiment on type 2 diabetes and without gastrectomy. So here's the position of the magnet exactly at 250 with closure of the mesenteric defect. So I'm going to skip the video for time. You know that the article is now in press in the Journal of the American College of Surgeons for type 2 diabetes only. We did 15 patients with a body mass index 30-35 with type 2 diabetes and no prior sleeve gastrectomy and no gastrectomy performed. You can see the body mass index is 33. The mean age is 53 years old. And we had 100% magnet formation, passage, and creation of the anastomosis. The median expulsion time was 24 days by the time they got by defecation. 3 subjects did not see the magnet passed. What we saw was an added weight loss, which we're not expecting. Just a small connection between the duodenum and the ileum gave a 40% excess weight loss at 1 year. But again, the anti-diabetic effect was very strong. We saw hemoglobin A1C moving from 8.2 to 6.5, 6.6 at 1 year. And you can see the fasting glucose as well. So after 1 year, we have seen that more than half the patient had hemoglobin A1C less than 6.5, or not the definition of type 2 diabetes anymore. That is the conclusion of our magnet anastomosis. And for those of you who want to see live surgery and hear more about this conference, we will go on to gastric, colon. I'm sorry, I'm giving a little advertisement on the Magnetic Surgery Symposium in Montreal. And as far as the Gila monster, this is what's going to happen in the next few years. We're going to see these monsters disappear. Thank you very much.
Thank you so much, Dr. Gagne. We are going to go to our last presentation. So after this 10 minutes presentation, we are going to have the opportunity to interact among the moderators and the presenters. And if we have other questions from the viewers. So our last presentation is going to be on safety indications and results of magnetic gastric anastomosis by Dr. Ribeiro from Hospital Luciadas Amadora from Lisbon, Portugal. Welcome.
Okay. Thank you so much by the honor to be with you. It's a pleasure to share our little experience about the magnetic surgery. I'm going to share my screen. And here we are. Okay. So I'm going to talk a little bit of an experience with gastroileal anastomosis with magnets. We know that there are different concepts of magnetic compression, circular magnets, articulated magnets, or even straight magnets for the Zenker diverticula, that they can work. Michel has just presented this experience with the duodenoileal anastomosis to perform the duodenal bipartition, which is a new good concept. We like it also, and we are related to the experience with that kind of operation. The outcomes are good. This is the series of 10 patients from the group of Guy Bernard Cadier in Brussels, 34.2% of total weight loss. The same with the Spanish group from Antonio Torres and Sanchez Pernalti, also 38.7% total weight loss, and a huge decrease of the hemoglobin H1C. You can see on the graph on the right corner, and the aspect of the duodenal ileostomy. And even last month, also, Laura Bierto has published the similar outcomes about weight loss with the articulated magnets from GI windows. It's another concept. But our experience is really with the straight magnet that Michel just presented before, connecting the antrum of the sleeve with the ileum. The indication for the gastroenterostomy with magnets can be different ones. In bariatric surgery, metabolic surgery, we have the bipartitions in 1 or 2 anastomosis, and we have also revisional surgery. For instance, when SADS can be with the problems of malnutrition, we can perform one entro jejunal anastomosis with magnets to fix the malnutrition. In oncologic gastric outlet lesions, we can do the same, the gastro-jejunal anastomosis. Magnets can be useful. Or even in cases of pyloric stenosis, or even in duodenal atresia, we can also perform the gastroenterostomy. There are several opportunities for so. Well, we were invited by Professor Michel Gagné to participate in the study to evaluate the outcomes and the safety of this kind of anastomosis. They were duly approved by the Portuguese authorities. And the indications, including criteria, were different ones, but we decided to go to the L corner and to perform the anastomosis in people with previous sleeve in revisional surgery to perform a gastroileal diversion. Because we are doing that kind of operation that was first called SAZI, single anastomosis sleeve ileal, but we prefer to call it OATB, one anastomosis transit bipartition. First in one multicentric study, even now the one with more cases in the literature, the total weight loss was 27% of the total weight loss. But it was very impressive the anti-diabetic effect of this kind of technique. That we have also published our own outcomes with 68 patients with more than 5 years follow-up, and the outcomes were similar, as you can see here. In this operation that we have done in our hospital with the precious collaboration of Professor Michel Gagné, we begin putting a magnet into the duodenum, as you can see in the right inferior corner. That magnet will progress to the bowel in a couple of hours. After that couple of hours, we make one X-ray to check the position. If the magnet progresses to the bowel, as you can see here, we go to the OR with the patient to perform one laparoscopy that I will try in 2 minutes to show you. We choose the place where we're going to put our anastomosis in the sleeve, in the antrum of the sleeve, if there is some. We go to the ileocecal valve and we measure the bowel in order to put the anastomosis, or we are going to put the magnet at, in our case, 300 centimeters from the ileocecal valve, which is the length that we consider fair for this kind of operation. We mark with some clips. We go to the trace angle, and we are going to another magnet to search for the magnet. that has evolved from the duodenum. You can see here. And when we find it, this is the moment. The magnets are docked, the two ones, the instrumental and the one into the bowel. And you surf the magnet into the bowel to the point that we have defined to be the place for our anastomosis. You can see here the clips marking our place. In that time, we put it in the proper position, a little bit of rotation, and we are going to join to the stomach where the endoscopist intraoperatively has put another magnet into the stomach, and we dock both. There is an assembling of the both magnets, and the anastomosis will be very safe and slow without complications. Well, we close also the Peterson space in order to avoid any kind of internal hernia, and this is the end of the operation. We close also the ports, but I won't go for that. The day after, we check the position of the magnets. You can see the contrast here laying down up on the magnets into the sleeve, into the gastric pouch. The 15 days later, we see that in this case that the magnets are still in the stomach, but there is already a fistula, a leak, and some contrast is going directly to the ileum. So there is some benefit, and after 30 days, the same case, no more magnets into the X-ray, they were expelled. And if you do contrast, we can see very clearly the omega of the bowel here and the duodenal arch also contrasting with some continence. This is the endoscopic aspect of the anastomosis. 30 days after, on the left, some edema, some enanthema, and after 53 days, completely different, clean, without any kind of redness, and very, very regular. So some data about our very little experience. We evaluated just people with 3 months follow-up. We operated on 10 cases, 9 were women, as I said, with 300 centimeters of common channel. There were no conversions of the laparoscopy. All the anastomosis are patent and functional without complaints. The average total weight loss at 3 months was 13.7. We can discuss, but there is a huge variation from 6 to 22. The expel time was 28.8 days, but there is one case that took 51 days. There is the regular one is less. And we had some events in 3 cases. One returned pair of magnets in the anastomosis without compromising the functionality of it, that we removed endoscopically right today, but the patient had no problems at all. One bowel perforation because of the surfing. There is a learning curve about that we need to consider. And in case of abdominal pain, that we also made the laparoscopy, but it is a non-conclusive one. This case, there was the one with the late expulsion of the magnet. You see it in the pelvic cavity, and only the expelled happened at 51 days after the operation. This is the retainer magnet in the anastomosis, see, like a bridge, and this is the image of today. We have removed the magnet, and the patient is very okay after that. Because of that, Dr. Michel Gagné and GT Magnetics decided to decrease the size of the magnet to 6 centimeters, and that one is the patient can swallow it, as you can see here, very easily, and it progressed very well to the bowel, avoiding the first endoscopic step of this operation. Some people, 3 patients had a low weight loss, but we need to consider that in this indication, the sleeve is not touched. So we didn't any kind of trimming of the pouch. There is a huge pouch like you can see here. And of course, that can compromise a little bit the outcomes of this kind of operation. But this is not the operation that we're going to do in the future. So our take-home messages from our experience, it's important to understand that we need a good cooperation between 2 teams, the endoscopic and the surgical one. We need adequate instrumental to have good outcomes. We need to think about the tissue handling that must be very gentle and avoiding bowel wall tears, and we paid a price in one patient because of that. 6 centimeters magnets may be better for this kind of operation because it's enough. We want 3 to 4 centimeters anastomosis in the future, and 6 will be easier to serve and to expel. And of course, if there is a dilated sleeve in the future, we should go for a trimming also. And consider there is a learning curve that we don't know yet how many cases we can consider. So to conclude, really, the advantages are this is really a safe anastomosis, standardized, it is operator independent, there are no foreign bodies, there is a reduced inflammation that will lead to less leaks and hemorrhages, less problems, and even less late complications like ulcers and stenosis. Of course, the patient will feel better with less pain, and of course with an easier nutritional protocol because they can eat properly solid food or smooth food at least more quickly. And as Michelle has already said, it is very easy to reverse because there are no foreign bodies. We can put a stapler and come back to the previous operation very easily. So that is one important exit strategy. Those were my messages. Thank you so much for your attention and a little bit of advertisement to our IFSO European chapter meeting in Venice, Italy in May. Thank you so much for your attention.
Excellent presentations, very interesting. And now I would like to open the discussion. If the other moderator has any questions, Anne?
Yeah, I have a question for Bethany. So for the TE fistulas, I mean, I'm not a pediatric surgeon, but I know some of them they're completely separated, right? Like it's completely separated. But are there some that also like have like a tiny little connection, like a fistula? Can you use the magnets in that scenario too, or no?
Yeah, so great question. There are a fair number of cases in which there is a fistula and the distance between the two ends of the esophagus are fairly small. So, in these cases, I think it is perfectly reasonable to do an operation. I prefer to do a thoracoscopic operation in which the fistula is ligated, and then you can perform an anastomosis between the two ends. I think it is also reasonable to place magnets in these cases, particularly for those that are technically not able to do the sutured anastomosis because you're really limited in the thoracic cavity by the rib space. These are usually, 1.5 to 2 kilo babies. And so it is a technically challenging operation. So I think that is a potential use for it to increase the minimally invasive nature of the surgery. If the magnets are used, though, in that capacity, the distal end does need to be closed first, though, because once you've ligated the fistula, you would cut it and it would be open. So the two ends would have to be closed first to use the magnets. So it's a little bit different than like a pure gap esophageal atresia case.
Got it. Yeah, that's pretty cool, especially, for that problem, for sure.
Yeah. Actually, when Dr. Slaty clearly presented that the regular surgical anastomosis it had a leak rate of 23, and the magnets was reduced to 10%. So that's a significant improvement that is very, very clear. But I have a question, if you don't mind, for all the before getting a little bit specific to different procedures. In general, what do you think, what is the influence, not of the magnets, but the tissue that you're going to put the magnets on to have different rates of strictures or scar formation? Because we can see that the bariatric cases, there is a reason for that. I love bariatric surgery, but they look gorgeous. They look like made by nature, almost, the anastomosis, right? But when we talk about other areas, there may be some difference with more stricture rates. So what do you think is the influence of the tissue on this type of magnetic anastomosis? Should we use them equally distributed on the body, or there is better results some places than others?
As the panelists are getting ready to answer that question, we'll just ask all the participants if they have any questions to place them in the Q&A.
I don't know the answer to that question because I have no experience on using it in cases of peritonitis and inflammatory bowel disease. In fact, everything that you can think of was an exclusion in the trials because we wanted to do this only on healthy tissue first and then find out how that behaves and probably go to more complex cases. You know, I can see that reversal of a colostomy you've created in the Hartmann's pouch. You know, if you had put the magnet at that time, it could result in very useful anastomosis. But maybe Anatole has probably more experience than me, could answer this question if it was used in Russia in peritonitis, unhealthy tissue, or you know, pathologies, bowel pathologies.
Thank you. That's a really good question. And as it was shown in our experience, the magnets didn't work on the stricture scar tissue. And I pointed it out in my presentation, when the healthy esophageal wall was not involved in the remodeling zone, then the compression acting directly to the scar tissue, in particular forceful compression, could cause a perforation. And it was the case in one of our patients in relatively small series. That's probably about the scar. So magnets shouldn't be really used just directly on the scar or extensive scar tissue. So it can be used for recanalization, but the healthy wall got to be included in the remodeling zone of MCA. That's first. About esophageal atresia repair, I think it should work really well, and the higher rate of stenosis might be related to that fact that no proper mobilization. It's done only in the transluminal mode, but the esophagus, the anastomosis parts, they still got to be really well mobilized, rid of all surrounding tissue, and they shouldn't be included in the anastomotic zone. That's a really important point too.
If I may, I would like also to add that
the magnetic force. Pardon?
No, I was saying
magnetic
that
force, magnetic compression is really
okay. So of course, scar will be an important issue that we need to consider, but also things like the foreign body. We have faced that problem in the patient with sleeve. They had some staples into the gastric wall, and that can produce problems and difficulties in the compression. But also factors like the age of the patient. We know that people with more age, maybe the tissues are more fragile. And also smokers, for instance, we know that are more prone to necrosis. So, but indeed, we don't know the right criteria, but in the future, maybe we can have, for sure, some guidance about that.
I have just a very basic clinical question. I mean, how do you manage the patients right after you put the magnets in? Can they start eating right away? Do they have to be NPO? Like what? I'm just curious, like how do you manage them in the immediate post-op period?
Well, I think it depends how the magnets were positioned, but in using the GT metabolic magnet, they're made for no enterotomies. So you don't change the lumen, you don't make a immediate connection, you don't cut the bowel. So these patients can drink right after. They can leave theoretically a few hours later, and they're usually eating normal food by the third day. Now, it's only when the anastomosis happened that you'll see some changes. These patients will tell you they have nausea, they have changes in their bowel movements, they may have some cramping. Some of them that monitor their sugar, it drops precipitously. So that's the beauty of not having to create an immediate anastomosis, but this is slow and progressive. Now, it's different if you have the magnets that are round or octagonal, where you do an immediate anastomosis, then you have the risk of getting a leak, and you have to advance the liquids in the diet as if you had done a stapled or a sutured anastomosis.
So basically, this is potential almost like an outpatient procedure.
In fact, we have done, I mean, in the United States, the patients were done outpatient in North Carolina, in some other states, in California, and the patients were done in the morning and then they left in the afternoon.
Yeah.
And my next question is, you mentioned that with 3 centimeters anastomosis, you had a very significant metabolic effect. So what happens if you do it bigger? You have a more weight effect too?
That's an abstract we sent to ASMBS, which got accepted and it will be presented. But just to tell you, I think we got 20% more for each centimeter of anastomosis of excess weight loss. So it makes sense. The bigger the anastomosis, the more flow you're going to get into the new connection, the more effect you're going to get, metabolic effect and decreased absorption of calories. However, there's a counterbalance point to that. If not enough is going in the natural pathway, you have potentially increased risk of malnutrition, decreased absorption of minerals and vitamins, and more problems. So where is the balance? We don't know yet. Is it a 50-50 flow? Is it a 60-40? I just don't know the answer right now.
Okay.
We have the same problems in the gastroenteroscopy, because in the OATB operation, usually do it with 3 centimeters. 3 centimeters is more prone to a shrinking of the anastomosis and the stricture, but we do it with 4. There will be a very immediate and strong ileal stimulation, and those patients have more diarrhea and are more in risk for malnutrition. So those are different dangers of the same anastomosis, and it depends a lot of the behavior of the anastomosis in the future. And those anastomosis are very, very clean, and I suppose they are not shrinking a lot. So it will help us to keep on the 3 centimeters concept in the future. Maybe it's a speculation for mine.
So we are about the time we have to close, but I want to say that I have been receiving texts from different friends from the States or even Argentina, happy with the presentation. So congratulations for all the presenters. And my question is for all the presenters and moderators. So it means that the fact that we have a new method for anastomosis with a very low risk of stricture and basically 100% success in the formation of connections and 0% of leak and bleeding. So is in the future the magnetic anastomosis the way to go?
Well,
I totally agree.
I think Anatole agrees, but I think it should be increasing part of our armamentarium. Just like, you're creating an anastomosis, you may decide to use sutures instead of staples, and you may have circular instead of linear, and now you may have magnets that are circular and linear, and I think it increases the choices of our toolbox. I would not say that it's 0 leaks, because as you can see, there was a small bowel perforation is coming from the manipulation of the intestine. There's always a risk in this. With instruments, you have to choose the proper instruments. And if you have fragile intestine, you can always cause a small cirrhosis there that can lead to a small perforation. So I think this risk is not zero, but it's very, very low.
Very good. So keep coming the message from Dr. Zaragoza from Mexico, and Ferreris, Argentina. So we are very happy with impact. So let's give Anne Lidor and Karen Gibbs the opportunity to give the final opinion on your presentations as a closing remarks for this exceptional webinar.
Go ahead, Karen.
All right, thank you. I think that this is really an exciting time in the field. And what I really appreciate about it is the meticulous manner in which we are moving forward with it and collecting the data. And as we are moving forward, I assume many of the people on this webinar would be looking to engage in the educational opportunities available in proctoring. I'm sure we're seeing such excellent results because we have excellent surgeons, both from an academic perspective as well as technically. And as we expand that, I'm sure they'll be very thoughtful as we move forward in identifying the optimal learning curve and what we need to do to continue to do bariatric surgery at the level that we have all become accustomed.
Well, I really enjoyed everyone's talk. Thanks so much for joining us. It's been, I wish I had a terrible redo case today. I wish I could have had a magnet for that one.
And I want to add that again, what Anne said. I want to remind you that on May, we have our annual meeting on SSAT. So if you come, I think there will be some presentations about this. So you can come and argue a little bit with Michel that he loves to the academic discussion. And we are already buying popcorn for that session. So we are going to enjoy that presentation, those presentation and discussion, but especially for the presence of all of you meeting once again in San Diego for the DDW, specifically for our society, SSAT. So thank you so much for joining us and have a wonderful day.
Thank you very much, everyone.
Thank you, SSAT. Thank you,
Thank you very
Sergio.
much.
So much.
Karen.